Hello, everyone. I'm Heather Banks, and this is Survivor Chat. I'm your host, Heather, a 10-year cervical cancer survivor, a wife, a mother, a teacher, and Survivor's lead advocacy educator and Survivor ambassador. At Survivor, we are all about how knowledge is power, and our Survivor Chat series is meant to connect you with people, experts in the HPV and cervical cancer field in order to gain new insight, get some new information, and maybe even some new perspectives in order to get another resource and educate and empower our community. Today on Survivor Chat, our focus is HPV testing and screening. And our guest is Dr. Mark Stoller. So I'd love for Dr. Stoller to introduce himself and talk to you about how he's connected to the HPV and cervical cancer community. Welcome, Dr. Stoller.
Thank you, Heather, and good morning to all of you in Survivor Chat land, I guess. My name's Mark Stoller. I'm a professor of pathology and clinical gynecology at the University of Virginia, professor emeritus, actually, a reflection of how long I've actually been in the cervical cancer field since I've been studying cervical cancer and working on guidelines and diagnostic testing algorithms and bringing better cancer screening to women for over 3 decades, almost 35 years. So with that introduction, I'd like to answer Heather's questions.
Awesome, thank you. Let's start with just some basic yet important information about HPV and its connection to cervical cancer. What is some information that you feel every woman should know about HPV?
HPV, or human papillomavirus, is a family of viruses that are incredibly common. We all have human papillomavirus infections on our skin and various surfaces. Some human papillomaviruses are sexually transmitted, and those are the ones that are associated with cancer development. These infections are very common. Most infections don't cause cancer. They don't even cause clinical lesions, but it's important to know that HPV is the cause of more than 99% of cervical cancer. So if you want to screen for cervical cancer or you want to prevent cervical cancer, you need to know your HPV status.
Yeah, I think when we give off information about HPV, women are just so amazed at how common it is. You know, over 80% is what they say of women and men too will have HPV, and it's just super common. And I think that's really important for our community to know too, because it kind of reduces the stigma that can kind of come along with HPV.
I think it's really important that there shouldn't be stigma, that, you know, acquiring an HPV infection, like many viral infections, is just really part of life. The important thing is to be able to manage that HPV infection, to manage your risk for developing cervical cancer, and be reassured that most of the time you can manage that risk very effectively with screening.
Ah, you mentioned screening. So I have had many friends in the last few years text me or call me after their their well woman annual exam. And what they say to me, they say, my doctor just told me that I don't have to have a PAP this year, that I can wait 3 years or maybe even 5 years. And they're concerned. They know my story and what I went through. And I think, you know, they're so used to having a PAP test every year, and they get worried and they're like, why is my doctor telling me this? So I'd love for you to speak to the change and the shift that we've seen in screening guidelines over the last few years. What are the changes? Why have they changed? And how has HPV testing been a factor in that change?
Well, HPV testing has been the critical factor in allowing us to make a change to what I like to call better medicine, right? So if we talk briefly from a historical perspective, we've been doing Pap smears for cervical cancer screening for about 60 years. And we never had a clinical trial that really assessed whether it worked or not. We in the United States and then other countries, because we demonstrated that it worked, just started doing it, and annual seemed like a good idea. Right? And then fast forward 40 or 50 years, and with the advent of molecular testing for HPV, the question was raised using much more modern science: can we do better? Can we do as good with HPV as we can with pap smears? And so the first real clinical trials to compare pap smears to HPV testing were performed. And it's from that science, that really hard science in multiple randomized trials around the world, that we've shown that you don't really need to be screened every year if you screen with a very good test, a very sensitive test. You can screen every 2 or 3 or even 5 years and do just as well in terms of protecting patients from cervical cancer while minimizing the harms of being overscreened. Now, this is something that a lot of women find strange. You know, this is America, more is always better. But it turns out that in medicine, everything is about balance. The benefit of screening versus the potential harm of screening. If you have a pap smear every year, it's very likely over 10, 15, 20 years, you're going to have an abnormal, and that abnormal is going to send you off for biopsies and other procedures that most people really don't need. So it's about optimizing screening in a way that maximizes the benefit, maximizes the reassurance, and minimizes the harm. And that's why all the guidelines talk about lengthening intervals, but doing better testing.
Mm. Yeah, so it's really about the tests that we are using, that they're more sensitive and they're able to pick up on a virus sooner. And so therefore we don't need to be testing every year because we have more sensitive tests and tests that are better.
Right. It's a combination of more sensitive testing, knowing what those tests mean, and also knowing about the risk associated with a positive or a negative test. Mm-hmm. So remember, most women, 90% or more women who come in for their screening test don't have cancer or precancer or anything we need to do anything about. So sensitivity is about reassurance for all those women who are really at no risk or at very low risk. And then you ask the question, well, how long does that reassurance last? So even if you acquired a bad HPV type the next day after your exam, is your risk of cervical cancer so low that we don't need to test you tomorrow, next year, 2 years, 3 years? And the answer is 3 years at a minimum, probably 5 years using really sensitive tests.
Okay, my next question is really meant for our survivor ambassadors, because at Survivor School, which is the advocacy training that Survivor puts on every year, where we gather cervical cancer patients and survivors and train them to be advocates, a question that we get every year is, and it centers around the guidelines. And we have women who have been through HPV and cervical cancer, and they understand the reason behind the shift in guidelines, but they bring it back to themselves, and we understand why they do it. And they say, well, but not me. If I had waited 3 years, they would have missed my cancer and whatnot. And they have a really hard time moving beyond themselves as an individual patient. And we try and we validate that, obviously, and recognize those feelings that they're having, but we do also try and shift their perspective to a more population-based guidance. Can you speak to that? Can you talk about kind of population-based guidance versus, individual patient guidance? And what about those women who are really concerned about, what if I would have waited 3 or 5 years, or what if I do wait 3 or 5 years?
Sure. So the first thing is, remember, these are guidelines, right? So, and in America, guidelines give you a lot of latitude. So if you and your doctor agree that there's something in your history, like we know before they changed the guidelines that you already had, you know, biopsies that showed precancer and you already had one treatment, you know, that might put you in a different risk category, and it might be appropriate to, on an individual basis, screen you more frequently. But that being said, the guidelines are pretty clear about managing the risk. And it's always, even though they're a population based, it's always put through the lens of the individual patient. So if we didn't think that the average individual patient was going to be safe doing every 3-year or every 5-year testing, it wouldn't be on the table. And there are ways of playing off the sensitivity versus specificity of the test. The levity of guidelines is critically linked to improved testing. And we know HPV testing is 30 or 40% more sensitive than the pap smear for finding existing precancer. So a lot of the people that survive in the survivor ambassador group may not have had HPV testing or co-testing when they reflect upon, oh no, I would have been missed. The other thing I need to point out for everybody in the audience is that perfection is not possible, right? So no matter if I use HPV testing or I use HPV testing and pap smears, and I do them more frequently, there's always going to be error in the system. The real change in the last 5 to 10 years is that the error has come way down because we've moved from a system which we thought was perfect but was really pretty flawed, that is pap smears alone, to a system where we can get much higher reassurance because we're being much more sensitive.
Absolutely. I would love to point out to our community that on our website, cervivor.org, we do have the guidelines, and it kind of spells it out for you nice and easy, because they can be confusing. And a lot of, I think your everyday woman is still trying to figure them out. So if you're still confused, or if you just like to, I even go and look at them again every once in a while to make sure I've got them straight. But those are on survivor.org with a lot of other great information too.
And unfortunately, guidelines, knowledge continues to evolve, and guidelines are changing. They're changing as we speak. So I'm sure you're referring to the American Cancer Society guidelines, which, where they were written in 2000, they were published in 2012. They started being written in 2010. So we're 10 years later, and there's, a new series of revisions that are going to unfold over the next couple of years, all of which are going to say 3 or 5 year screening.
Yeah. Before we move on to our next question, can you just quickly state what those guidelines are?
So the guidelines basically say everybody between the ages of 21 and 65, special circumstances notwithstanding, needs to be screened for cervical cancer. Between 21 and 30, the guidelines recommend pap smear testing every 3 years. And over age 30, the current guidelines recommend co-testing every 5 years. Co-testing meaning HPV plus a pap every 5 years. Now, various iterations that have come out through 2010 have minor tweaks, but to those recommendations. But the bottom line is, you need to come in for screening, but you don't need to be screened for cervical cancer every year.
Yeah. We always like to say and promote your annual Well Woman exam. That's kind of another thing that we've seen with this shift in guidelines. We think when women tend to hear, oh, I don't need to go back to the doctor for 3 or 5 years. And at Survivor, one message that we are, really clear at sending is, the guidelines say that you might not need to be screened for HPV until 3 years, but you still need to be going to your doctor for your well woman exam because, as you just mentioned, lots of other screening takes place at that important appointment. So
I think that's absolutely true. I think, unfortunately, too many doctors and patients link annual doctor visits to cervical cancer screening. And really, cervical cancer screening may or may not be part of your annual visit, but your annual visit is your annual visit. And there are other reasons to go for that annual visit or every 2-year visit. It depends upon, what else is going on. Do you have symptoms? How old you are you pregnant, et cetera, et cetera.
yeah. So we've mentioned pap testing, and that's what a lot of women are familiar with. You mentioned co-testing, which is becoming more and more common. There's this other element out there, this other way to use the HPV testing technology, and it's with what we call primary screening. In a second, I'm going to ask you to kind of compare the three of them. But before I do that, will you just give our audience a pretty simple and basic understanding of what is HPV primary screening?
So HPV primary screening is, in my opinion, how we should be screening. And I say that because, remember, we talked about changing the guidelines based on data, clinical trial data from very large randomized clinical trials that have been performed all around the world. What HPV primary screening means, instead of doing a pap smear or a pap smear and an HPV test, we do an HPV test. We test for virus that puts you at risk for cancer and the precursors of cancer. If you're negative, we know that your risk of developing cervical cancer or precancer is incredibly low. I mean, we're talking tiny fractions of a percent. And that maximally reassures all the patients who are negative, which is more than 90% of the patients. If you're positive, then we do a second test to figure out if you really have something that needs to be referred for observation or biopsy, so-called colposcopic examination. And currently that's using the pap smear not as a screening test, but as a triage or a test to get you to colposcopy or not. So primary screening basically means test for HPV. If you're negative, come back in 3 or 5 years. If you're positive, get a pap smear on that same sample. You don't have to go back to the doctor or anything. And then if the pap smear is abnormal at all, get colposcopy. If the pap smear is normal, then you're HPV positive and pap negative, and you would come back in a year to make sure that your HPV testing results resolve or not.
I remember a friend texted me once. I think I mentioned maybe that she should be asking her doctor if they do HPV, co-testing or just testing in general. And her response back to me on the text was like, well, isn't that the same thing as a pap test? There's lots of educated professional women out there who just don't know the difference between an HPV test and a pap test. So I'm going to ask you to compare these. Really, it's two things: pap tests and HPV testing. But with HPV testing, we really have the two different realms of co-testing and then primary. So how do you compare pap alone versus co-testing versus primary screening?
And I agree it can be confusing because really what we've been doing with pap testing is screening for cervical cancer. And what we're doing with HPV testing is screening for cervical cancer. So pap testing, basically pap testing is we scrape the cervix and we put the cells that we collect in that scrape under a microscope, and we look for abnormalities under the microscope. Microscope is right here. with HPV testing, we take the same cells in the same vial, in the same collection, and we take a portion of them and we look with a molecular chemical assay for the presence of one of 14 different HPV types. And so you can be screened for cervical cancer with a pap test that looks for the abnormalities under the scope. You can be screened with a cervical cancer screening test that looks for HPV molecularly, or you can do both. What I alluded to before is that all the data from the last basically 20 years has shown that the HPV test is more sensitive than the pap test for identifying people at risk for having cervical cancer or one of the precursors that leads to cervical cancer. I keep bringing up precursors or precancer because that's really what we do in the United States. Most of the women who have positive tests don't have cancer. They have a precancer. Some of them have a precancerous lesion, and it's by treating that precancerous lesion that we prevent cancer, which is what we really want to do. So HPV testing is way more sensitive, 30 to 40% more sensitive than a pap test that looks just at the cells. And the point is that gain in sensitivity is what you want in a screening test. You want high sensitivity means maximal reassurance, but you're also balancing sensitivity and specificity. You're balancing the benefit of telling the people who are negative that they don't have cancer while minimizing the risk that if it's positive, you get referred for colposcopy so that you don't get referred unnecessarily. You don't have excess biopsies. So what does the science show? What I alluded to before is that HPV testing was better than pap testing for cancer screening. So in my mind, what that means is after age 30 and perhaps eventually after age 25, all cervical cancer screening tests should include HPV testing. Now, we could do HPV primary screening, which is simpler because you only do one test and then you do the second test on, let's say, 10% of the people or 15% of the people. Or you can do co-testing and do both tests on everybody. The science very clearly shows that co-testing, and this is where it's sort of a not intuitive or counterintuitive result. You would think that co-testing would always find more cancer, would be even more sensitive, but the data are, when you follow the recommendations and you follow the algorithms, it's not. So why do we do co-testing? We do co-testing because we didn't have primary screening data in the US to allow an FDA approval for a primary screening test for over 10 years while we were bringing forward co-testing as a concept. So the first primary screening test was approved in the US in 2014. Co-testing has been around since about 2001. So to summarize, the best cervical cancer screening is really HPV testing with or without a pap smear. But if you look at the data as to what is most efficient for the system with no harm, all benefit, primary screening in my mind is the way to go. We'll see if the world eventually agrees. Outside the US, the world clearly agrees. Most of the countries outside of the United States that have organized screening, where they never have done co-testing and never will do co-testing, are moving from pap smears to HPV primary screening.
Yeah, you just answered my next question, which was, are there any other countries that are really relying on the primary screening as their main screening method for?
Right. And these are countries, these are countries your audience has heard of, right? Like Australia and the Netherlands and Sweden and Italy and England and, Canada. Then very many places are ahead of us in terms of their thinking. about potential primary screening. Not every one of them is doing it right today, but all of them have this conversation on the table, and none of them are talking about co-testing because of the data we're talking about.
Well, hopefully we will get there. I know all this takes a few years, and it takes time to implement and to change people's thinking and practice. So I know at Survivor we are super hopeful that we will get there one day, simply because we want to provide people and patients with the best tests that are out there and that are possible. So that's great. Okay, my next question has to do with probably the United States Preventative Task Force. They have a draft out there that is kind of messing with the current guidelines a little bit. What are those changes that they are recommending, I guess, in that draft, and what does it mean for women?
Okay, but before I answer that, let me comment on, where we ended up, right? So in my opinion, for your audience and for all women, I think the issue is certainly after age 30, and personally, I think it's after age 25. If you're going to be screened with an HPV test plus or minus a PAP, because it's better screening, it's more sensitive. Now, you're not going to find that exactly in the guideline, excuse me, and this is a nuance, if you will, about, these sort of trade-offs between sensitivity and specificity, about benefits, harms. Another one of the problems with the guidelines is they're too complex. A lot of countries are looking at, a single guideline for all women 25 to 65 or 25 to 70. Makes it simpler. You don't have to remember, if I come in at 29 in 10 months, do I get the 21 to 30 guideline, or do I get the 30 and older guideline? You know what I mean?
Yep.
Okay, so the United States Preventative Services Task Force is one of several groups in the United States. You can tell from their name, it's a government organized group that looks at screening tests and other types of healthcare recommendations. They have recommendations about mammography and prostate screening and colon cancer screening and cervical cancer screening. And their last guideline came out at the same time in 2012 when the American Cancer Society guideline, which is the current major guideline that's out there. So it's now 2012, 2018, 6, 7, 8 years later. The United States Preventative Services Task Force has been reviewing the current evidence of the last decade and have posted in the last several months their draft recommendations for an update. And their update really rocked the cervical cancer screening world, if you want to put it that way, because in 2012, remember that was before the first FDA-approved primary HPV test, all the USPSTF talked about was pap smears. Pap smear screening every 3 years. That was basically their core recommendation. And their new draft recommendation for 2012, based on their, you have to say, the USPSTF is an independent body, right? They make every effort to be sort of independent of industry or independent of vendors, and really, try and do an objective independent review of the literature. So what do they recommend? For women aged 21 to 65, their draft recommendation is to, again, have long interval screening. For 21 to 29, pap smears every 3 years, because the risk of cancer is low in that decade, and the specificity of cytology is high. So every 3 years is felt to be perfectly safe. But for women over 30, instead of co-testing, they talk about HPV primary screening, and they talk about HPV primary screening every 5 years. And that's really the core of the guideline for the majority of people. The rest of the guideline is things that are similar to what was in the prior guideline. That is, if you've never had an abnormal PAP or never had precancer treatment and you're over 65 and you've been adequately screened, you don't need screening anymore. If you're younger than age 21, you don't need to be screened for cervical cancer because we changed, more than a decade ago to not screening women younger than age 21 because it doesn't lead to any real benefit as long as you start coming in somewhere after age 21. And if you don't have a cervix, you don't need to be screened for cervical cancer.
Mhm. So we just kind of wait and see kind of what happens, I guess, huh?
Well, I think what's happening is they put their draft out. To their credit, they for months they had their website open for comment. Organized pathology and organized OBGYN and interested parties. I'm sure they made many, many comments. I have no idea how many, but based on experience, hundreds, if not thousands of comments. And then the panel will take those comments under advisement, see if they want to change their recommendation or not, and then they'll post the recommendation. Meanwhile, in parallel, I think the American Cancer Society is also in the process of working with, other organizations collaboratively, potentially going to revise their guideline and tweak, whether they agree that co-testing really should not be done if we have primary HPV testing or not. We'll just have to wait and see. But I think what you're seeing is the USPSTF is really reflecting the evidence that's driving the rest of the world towards primary screening.
I think that, I have a 13-year-old daughter, and when I was diagnosed with cervical cancer, she was just 3 years old. And there has been so many changes just in the 10 years almost, since I was diagnosed. And I think of, myself when I was diagnosed in 2008, when she was 3 years old, till now when she's 13, and then, 10 more years when she's 23 years old. And in the span of one generation, there's going to be a lot of change and a lot of positive change in the whole HPV and cervical cancer space. And it's pretty cool to me when I think about how, again, just in the span of one generation, there are so many changes happening that will prevent her and all the young women and girls that she represents from having to go through what I had to go through and lowering the risk of cervical cancer in their lives. It's pretty.
Well, I certainly agree with you in that change, that better world for your daughter and all our daughters is being driven not only by better cervical cancer screening methods, but by the HPV vaccine.
Yes.
She's the right age for the HPV vaccine. And I can tell you that, Gardasil 9, which is the HPV vaccine that's currently available in the US, will eliminate the risk for 90% of cervical cancer and its precursors. So that when your daughter is 23, the likelihood that she'll have an abnormal PAP test or an abnormal cervical cancer screening test it would be about 10 times lower than it would be for the average person today who is 23 and not vaccinated.
That's amazing. That's amazing. And I think you just gave us an idea for another Cervivor Chat in the future, which is obviously the vaccine. And there's so much information about that. So we'll have to dive into that at another time. But I think.
Happy to do that. I was part of those trials, so I know a bit about it.
Well, and the gist, I think the overall message is with HPV testing and the vaccine, we just have so much that we can do to really eradicate this now preventable disease, which is really exciting.
So that's a simple message for all of your audience. Screen the moms and vaccinate the kids.
Ooh, I like that. I like that. Dr. Solar, thank you so much for your time today. I know that our audience, whether they're survivor ambassadors, women that we have started to train and continue to train, or whether it's people who are just out there, everyday women who, interact and hopefully are proactive with their gynecologic health. I think all this information is just so important for everyone. So thank you so much for your time. And for our audience out there, please remember that you can connect with us on many, I'm going to share my screen here, many different levels. We have our website, which is cervivor.org. There's tons of information on there, and even stories. Dr. Stoller, I don't know if you've checked out our stories page yet, but there are women who have graciously uploaded their cervical cancer and HPV stories from around the world, different races, different ages. It's just amazing to see, and we keep getting more and more stories. So all of that is on cervivor.org. You can connect with us on Facebook at Cervivor, and on Twitter and Instagram at I Am Cervivor. And you can always email info@Cervivor. So I hope that everyone enjoyed our Cervivor chat today, and we will be back in the future with more information and more experts in the field to provide and empower all of our audience with the knowledge that is out there and the knowledge that they can really use for their own health. So once again, thank you, Dr. Stoller.
Thank you, Heather. My pleasure. And yes, I've seen that, the story page. My daughters and my wife and everybody really like to see the enthusiasm and the support that's out there for women facing these challenges.
It's pretty awesome. I'm glad you've checked it out. All right, everybody, until next time, be safe and take care of yourselves, and stay tuned for information on our next Cervivor Chat. Take care.
Bye.